on community-based hepatitis testing. My name is Daniela Rojas Castro. I have a PhD in social psychology. I've been working for 23 years in the HIV, hepatitis, and in the health sector, mostly conducting community-based research and also implementing activities and innovations based on community-based research as community-based testing, PrEP provision, etc. Today, I will be leading this session, and I'm very happy to be with you. And I have some requests for you. I think that it would be great that I am not giving a masterclass for 90 minutes, but that we get to do something that is going to be collective. So for those who can or want, please show your faces so I can see how the things are going on. And please don't hesitate to speak with me and provide your input. I am really convinced that the best way of learning things is not master classes or nothing like this, but exchanging with people that have different experiences, etc. So please don't be shy. And I want to start with something funny, because we have several people here, and I would like to know from where you are. So we have an idea of which countries and then which kind of models, legislation we have regarding community-based testing. So I really hope that this works. So please take your phones, make a picture on the QR and tell me where are you. And I will do so too. So London. Okay. A lot of people from the United Kingdom by now. Some South Europe. Great for the others. New Zealand, wait, Armenia. Okay, so we are from very different countries and very far countries. There are only 12 people. So are the others comfortable with Menti? If you have questions, just tell us, because we will use it later. We will use it later. Well, thank you for that. I can see that we are coming from very, very different countries and contexts, and maybe this can be a very good way of showing how different cultures and legislation behave regarding community-based testing. I could speak about experience on community-based testing in France and Spain. That is where I have worked the most. But it's very interesting to know how in different countries we have very, very different ways of doing and situations. For example, the Canadian one, where even nurses are not allowed to do testing. So we are moving forward. And first of all, I would like to say, why are we here today and why World Hepatitis Alliance has decided to do this workshop. For us, it was very important that during the World Hepatitis Testing Week, we needed to do an effort to raise awareness about the need of testing regarding hepatitis. You know that during this week, there are a lot of people and a lot of structures that are going to be around the world communicating, conducting specific activities and promoting testing that will allow diagnose, treatment, and ultimately to eliminate hepatitis. We know that at this moment there is a significant unmet need to scale up hepatitis testing. So there are millions of people globally living with hepatitis without knowing it. I think that you are all aware of this. And what we know is that without this awareness, these people are missing out vital care, treatment, and preventive services. So early testing is key. And what we are going to try today is to see how community-based testing can be a facilitator for promoting this testing. So let's move to this other one, because I have my idea on what we can speak about, but I would like to know if you have any specific things that we want to discuss or to learn today. So can you please tell me something about what is the motivation about you coming today? I'm sure that I won't be able to respond to everything, but at least we can know, and if necessary, we can organize other extra workshops or communicating on the website of World Hepatitis Alliance. So earn extra knowledge. Tell me that you have other motivations. I mean, other people. Okay. We love that after you can present what you are doing for this community FC screening. Great. We will speak about this. Okay. Low prevalence settings. Great. Any others? Okay, I think that regarding hepatitis testing week is not going to be exactly the topic, but what is sure is that the kind of activities that community-based testing allows can be used for the for the testing week. I don't know if I am clear. Well, okay, I have an idea. Thank you for that. What I would like to share with you today is from one to start to understand different hepatitis tests. We have two type of tests, and we would like to know what do we know about them. Some practical knowledge on testing, awareness on how we should handle the things regarding cost, and then how concretely we can implement community-based testing. And this is something that is going to be very, very conditioned by the countries and the cities where you live. But first of all, I would like to start, and then you need to speak now. Why do you think that testing is important? Why we are organizing this workshop? Why do we want to implement community-based testing as an extra way of conducting testing? And can I have your thoughts on this? Please raise your hand and speak. Gavin, I cannot see everybody, so just go ahead.
Yeah, hi, Daniela.
Hi, Gavin.
Thank you very much. Community-based testing just makes so much sense. I mean, it's been established and proven after Egyptian programs and various other programs around the world that test to treat, screening to treat programs at a community level are really efficient. Now, if we start to look at the AB versus RNA type testing and how the programs are actually enabled and enacted within the community, your cost savings can be millions to billions of dollars, especially if you're looking at population-wide. So community-based testing makes absolute sense.
Okay.
It's just shown that the politicians and a lot of the current statist physician community seem really, they just don't want it. There's so many hesitations out there at a professional level that it becomes very concerning.
I agree with you, Gavin. We can discuss about this and about potential ways of convincing governments to develop more of this.
Yeah, I could go on for hours, but just so you know, I was the national program manager for the Hepatitis C implementation program in New Zealand, and I'm literally just finishing my master's on, which has been specifically on community testing.
Okay. Well, thank you, Gavin. I don't hesitate to ask things during the workshop, please.
Thank you.
Others? Justin, I can see if they are raised hands.
Yeah, nobody is raising their hand just yet. But feel free to just unmute yourself and speak up if you want.
Maybe I can chip in. I don't know if you can hear me. It's Danny Morris here from the UK. Hi there. Morning, everyone. Yeah, our experience in the UK is very much based around a really significant partnership between organisations, particularly the Hepatitis C Trust, the organisation I work for, working with people with lived experience. The majority of our staff are people with lived or living experience, and we have a very, very close relationship with NHS delivery, so that I think it's increasingly recognised that reaching out to communities of people largely at risk in the UK, the larger community of people with Hep C in the UK are people who've contracted Hep C through sharing contaminated injecting equipment, for example. For 95% of people in the UK, that's the case. And we've found that to reach those communities of people who are very much tend to be marginalised, tend to have poor access to health and social care provision, and you know, these are broad generalisations, but overly represented in terms of multiple kind of needs, housing issues, mental health issues, and so on and so forth. I mean, that's a generalisation, but not untypical. What we found is that kind of peer-led work in partnership with the NHS teams has been incredibly productive. And there's no doubt that our peers have access to communities that otherwise kind of people from more professional, to use that term, more established kind of health provision are unable to do. They rarely have the time. They rarely have there's no lack of empathy from healthcare provision particularly, although stigma is clearly an issue for people, but we're finding, we know through 5-6 years of experience now, the peers have a really fundamental role of working across communities, not just testing, but educating people, reassuring people around the processes once testing has been undertaken, the ease of treatment, the fact that we're in a position to support those people through the whole of that treatment process. And again, give reassurance, you know, broadly speaking, wrap a comfort blanket around them, you know, and I think there's something we've learned that Hep C is so easy to treat, so easy to diagnose, but there's rarely a day goes past when we're not managing people who are still, even when they're expected to get Hep C positive test result. We use various technologies, which I can come to later. You know, people often need that reassurance and often kind of really, really fearful still, because their experience, typically people with a history of drug use or current drug use, their experience of health and social care is often quite compromised. You know, they're often feel ill-equipped, typically judged. So you've got a whole host of barriers that peers in terms of community testing clearly can help overcome. That's our experience absolutely across the UK.
Thank you, Danny. So I think that maybe I will keep one question that we can discuss later, that is regarding monitoring and evaluation on community-based testings, because as Danny was saying, it's something that in many countries is is working, some countries are doing, but I would like to know what do you think about what are our efforts to monitoring this activity and to present this data so we can do advocacy on the effectiveness of this kind of testing. And then this thing also regarding linkage to care, because we are providing community-based testing, which means that we have peers, etc., and we are taking care of the populations that need it most, and then linkage to care can become difficult if the health system, the classical health system, is not working with the same cultural adaptation that we are doing. But this is something that we can discuss later. Inga.
Hello, everyone. So I'm working for the project, the Hepatitis C project, and our target population is the key population defined for HIV is the same for Hep C. And what we notice, we provide all services free of charge. We try to make it as accessible as possible in terms of transport, the location, information sharing, etc. But we notice that people, so it's more maybe health seeking behavior related, but people tend to not come to healthcare services if they are not sure that they have a problem. So in this term, I see that changing the testing into community instead of waiting for them to come proactively for testing and then knowing that they have Hep C to go to undergo the rest of the diagnostic and the treatment will make a big change. No? Well, it's like a changing to change. I mean, like if they will know that they have Hep C, they will be more motivated to reach health center. So I am here to learn how it can be done, knowing also that in the country, of course, I want to see also the methods we are using. We need to have, we are doing here only with the rapid tests for which we need to have a licensed nurse who can do that.
Yeah.
That makes it difficult to make it in the community because when we still talk about the community, we talk about peers or we talk about community-based organizations who are not medical, who don't have medical license, etc. So I'd like to learn here what other ways can be implemented and maybe also to replicate in our project.
Can you please tell me where do you come from?
Armenia. So the country is Armenia. Sorry, it's Armenia, Yerevan, the capital. We do the project.
Thank you, Inga. Dilani?
Yes, sorry, I have a problem with the camera. Yes, I think the things I wanted to express, already these things have been mentioned by previous speakers. Mainly, it increases acceptability and accessibility, obviously, when we go to the community. The issue is you need to have rapid tests, point of care tests when you reach community. So availability of rapid tests will definitely affect our service provision. I feel we have to go to community because in our country also key populations, we do outreach programs. In prisons, we do screening programs. So in these, there's more acceptability and accessibility to services by providing services in the community. So I think other views expressed by others, I also agree. Thank you.
Thank you, Dilani. Can you tell me where do you come from? Please, when you speak, tell me who you are and the country. So
yeah, I'm Dr. Ilan Rajapaksha. I'm a venereologist having about 30 years experience in STI and HIV services and from Sri Lanka. Thank you.
Thank you, Dilani. Any other words? I think we have more people, no? Okay, I really think I have my PowerPoint with different points, but I think that the things that you guys are already telling me are things that maybe we can discuss in group later. So, Garba, go ahead. Garba?
Thank you. Good morning, all. My name is Dr. Garba Danjuma.
Yes.
I'm a consultant public health physician from Nigeria. I'm the chairman and founder of Women and Children Health Empowerment Foundation, WACHEF, a voting member of World Hepatitis Alliance. So as a community-based organization, we have a lot of focus in the area of women and children. We ensure that we conduct community outreaches, especially targeting pregnant women and children. What we do mostly, we integrate a hepatitis program into our other existing programs we are doing. For instance, we have a project we are doing with Action Aid. We ensure that whenever we go for those programs, we integrate the issue of awareness on hepatitis, we integrate testing, and also we integrate vaccination. But the challenge we're having is in Nigeria, the hepatitis vaccination and even is more targeted to the children. There is no provision for the adults and even members of the key population. So as CBO, what we do is we procure our test kits. We also procure the vaccines. We ensure that we have a very good cold chain. And we subsidize, we do the testing free. Is the vaccine that we're having challenge? Most of the time we have to purchase, we have to procure the vaccine ourselves. So we try to provide a kind of a token. The recipient pay for little charges, but at the end we supplement the charges so that they get the vaccine. Because it doesn't make sense testing somebody is negative for hepatitis B and you cannot vaccinate the person. So I think we are doing a lot, but one of the challenges we're having is the issue of the supplies of the test kits, commodities, and vaccine. But as CBO, we're trying to supplement since there is no program of government targeting adult population in the country. And similarly, for pregnant women, it's very critical to us. We ensure that they have testing for hepatitis B and C, and then those that are positive, we ensure they are enrolled into treatment, and the treatment is also not free, unfortunately. So linkage to care is very critical because if we have test and treat, if those things are there, to be easy for the pregnant women to have their treatment. But sometimes they are positive, but the medications are not there. So at times we have lots to follow up, missed opportunities. So by monitoring, that leads me to monitoring and evaluation of the program. As I said, we integrate hepatitis into all our programs in our organization. The monitoring aspect, there are tools for HIV. However, we don't have dedicated tools for reporting for hepatitis B program. But I know the federal government, the Federal Ministry of Health is doing a lot of work to ensure that we have standardized tools that we can report from the community level to the health facility, and health facility to the LGA to state and to the national level. But as an NGO, we have a database where whoever we test, we take the age, the sex, the some information on the knowledge, information on risk factors, and that was why some of this data were able to analyze. We presented an abstract at the last World Hepatitis Summit in Portugal, where two of our work we did in this NGO with key population, and then especially the PWID has been accepted, one for oral presentation and the other one for poster and the last World Hepatitis Summit. So we have a robust database in this organization for the past 4 or 5 years, where we can have all the indicators that we can analyze. So I think we have a system for monitoring what we are doing. We disaggregate our data based on the age, based on the sex, based on the risk factors, whether they have been tested before, the prevalence. So we have all this. The prevalence, we are seeing prevalence of almost 12, 13% for, in fact, in some places 15% for hepatitis B, while hepatitis C around 3, 4%. So we have a system of monitoring at all levels. I think these are the things we are doing for now, but we're open to hear more from other colleagues from other parts of the world to see how we can make this first hepatitis testing week a success in our respective countries. Thank you so much. Over.
Thank you, Garba. Armand?
Thank you very much. My name is Armand Savavagano. I'm in Bujumbura, Burundi. As I come to write in a chat, I'm a member of BAPOD, but I'm working in a Ngirankabandi activity, which is a project funded by USAID. So what I'm going to say here in Burundi, we don't have a vertical program of testing in the community. People, what I was going to inform you is that hepatitis C and B is here in our country. For example, last time, as I mentioned in the chat, the project is focusing to HIV. It means prevention, it means treatment, it means treatment, yes. During the prevention, there is people who came to our office. He was requesting PrEP, prophylaxis pre-exposure HIV.
Yes.
Is HIV negative. We give them the PrEP like this. But if you want to come again to take the PrEP, we must look if you don't have other disease. So last time we find people with hepatitis C, 2 people with hepatitis C. This means it is a proof that hepatitis is there, but we don't have a vertical program of it. So I came here to gain more knowledge in order to see that if we can launch in our country a vertical program of hepatitis, because we don't have it. But what a good news is that the Burundian government launched a free hepatitis B and C treatment since last year, but PRIO is given to people living with HIV. If not, you have to pay hepatitis viral load, which is expensive here. So I hope to gain more knowledge here. Thank you.
Thank you, Armand.
Yeah.
I think that you are providing very good examples of what are the challenges of community-based testing in different countries. And I don't know if instead of following absolutely the order of the PowerPoint, maybe we should discuss on some of the topics that have been addressed here. Because, for example, when we speak about monitoring and evaluation, that is something, I mean, from a scientific point of view and for doing advocacy, it is clear that we need data. We need data to justify, to implement community-based testing, to improve what our strategies of community-based testing are, because they might change with the time. Here, there is people that have a lot of experience with this, like Danny, for example. So maybe just jump in if you have ideas on these kind of things. And what we know is that we are most of the time very we need to respond to our funders, and this funding thing is going to affect the kind of monitoring and evaluation that we are doing. And what some of the and I think that one of the problems with this issue is not only that different structures are having different tools for monitoring and evaluation, but also that the indicators that we are using for community-based testing are maybe not the most adapted, and not always what we are evaluating in monitoring is things that can help to the community providing the testing and to the users. I don't know what are your thoughts on this, and how do you think that we can change this? Gavin.
Thank you very much. And excuse me if this is too much of a personal opinion, but it's a very common thematic points that we're hearing all the time, and a lot of it is around the data, the funders, the funding. And sometimes I really feel that it's almost like we're holding ourselves to ransom in bending over to meet the requirements of the funders. I don't feel that necessarily we're presenting them with the right information. I mean, the data is there. It was established in Egypt. It's been established in so many countries that community-based A/B testing works. It's also been really firmly established that RNA-based testing, although definitive and effective, is incredibly expensive, and very, very few countries could implement a population-wide program. And it's been established that we need population-wide programs to ensure we can get towards elimination. It's a very much a key to the whole thing. But what I've been hearing over the last 12 months is a lot of echoing of the World Health Organization's global statements, and they finally put some action points with those. And we're just hearing echoes of those coming out of all the different organizations, hearing a lot of people talking about the importance of data. When we're talking about a population-wide screening program, what's more important, gathering the data to show that it works, or letting the program actually generate the data sets that we need when we've already got them? So yeah, even though I feel that we all recognize the importance of community-based testing, I don't believe that it's been elevated to the level that it needs to be at. A lot of our traditional medical community are still viewing this, that RNA testing in a laboratory has been established as the definitive way to do it. So therefore, that's how the programs need to be focused. In saying that, though, I am aware that there's some legislative restrictions in some countries, and I believe Armenia is in there with Australia, where you just can't go out and antibody test. Whereas in New Zealand, you can bring whatever in vitro test you want into the country and anybody can use it. So we're quite fortunate on that. So having a mind more than anything.
No, thank you, Gavin. I completely agree with you. Danny?
I'd echo those recent kind of comments, really. I think I'm mindful that we are incredibly well resourced in the UK compared with many other countries, so I understand that. But we've found very, very clearly that antibody testing alone has very limited impact, if I'm honest, because the challenge is to find people again. It's not as straightforward finding people, particularly in the communities that are most affected. If you do an antibody test, it tends to create huge anxieties for people. You know, people still don't fully understand what antibody testing actually means for them. And we've had significant increase in results when in the community we deliver RNA testing through dry blood spot testing. So all of our peers will go out to do Hep B, HIV, and Hep C testing using dry blood spot test. Quite a few of our projects use point of care testing with Cepheid gene expert machines. You know, so in the area that I'm responsible for, one of the areas I'm responsible for in Birmingham, West Midlands, population of 6 million people, our peer team deliver the Cepheid testing programs, supported by the NHS. So we're trained by our NHS colleagues who effectively commission our work. And it means then that we can give people their test results within the hour, which has a massive impact in terms of engagement, absolutely massive, because our peers can hold on to people in that period of time. They're having a chat, having coffee, giving them education, some harm reduction interventions to look at what they may need to do to reduce the opportunity of reinfection and so on and so forth. Sometimes just a bit of care, compassion is really important for people who are often kind of very, very wary. So that works well. And even with the dry blood spot test, we typically get the results back within 2 weeks. I accept when you're looking at the genotypes, their cost, but we're very lucky to be able to deliver those tests. But even a 2-week window gives us a much greater opportunity of finding people as opposed to just doing antibody tests, bring them back in, getting them for an appointment somewhere, to have another succession of blood tests. And I think it's with the technology that's available now, I think I would like to see, you know, all countries adopting it really because of the results. You know, we are continually trying to finish here. With our extensive program, we are still finding people who are unnecessarily cirrhotic, people who have been antibody tested for 5, 10, 15 years ago, have been lost to follow up in the system. We're finding them and they're cirrhotic, which is really bad news. Okay, and I think, so therefore the speed of response is absolutely essential because the more barriers that we have in place, cultural barriers, practical barriers are in place, the less likely we're going to, one, find and two, be able to support those people into treatment. So I think rapid response around testing, comprehensive testing, is undoubtedly the way forward, although I absolutely respect some of the challenges that are out there in terms of allowing that to happen. But to finish here, I think our peer program has led that way. I mean, what happened, our peer program influenced change in patterns of testing. It wasn't the other way around. Our peers were consistently worked closely with nurses and hepatology leads, you know, who've recognized more and more the benefit of that, the model of testing that we've kind of proposed and put forward. So it's a partnership work that works really, really well. It's not an opposition in any way at all. It's that partnership, yeah, that works as really effective.
It's just so I was just going to add in there, Danny. You're very fortunate in the UK. I think you're in quite a unique position with programming, and especially I'm starting to notice some of the personalities like yourself that have been real driving forces behind that. It's really helped out. What's become very obvious was an iTreat study done in the UK, which was a physician-based test to treat in place program. There's a few Canadian programs that have been done, and I see there's a few European initiatives that are starting up again based on previous experiments, which are all based on what you've been talking about. And what's really key in those is that they're clearly identifying the weak point is the delineation point where the handover occurs between that initial test and getting them into a treatment system. And I think that's where you guys over the last 2 years in the UK, I've noticed you've made some great headway into peer management around that, whereas other countries aren't. They're still really reliant on that traditional workforce. There's a big Californian study, incredible successes and take up rates with testing. Lost almost everybody once they handed them over to primary care. And the primary care consisted of hospitals, GP clinics, outreach clinics working with the PWID. So, but the commonality was the peer was no longer involved. So like you said, critically important, the peer being involved right through the handover, the linking to care and the continuation. So yeah, sorry, just wanted to really emphasize that. It's really important.
I think that what you are saying is really, really important because there are a lot of studies regarding this linkage to care thing, because it's like if we had a black hole between the fact of doing a rapid test or a community-based testing and then getting into the health system. We don't know what happens there. And there is also an issue with sorry, I'm this note taker, distract me, with the definition of linkage to care. And this is something that some European projects have worked on. You can find information. There is the COBA test and Euro HIV EDAT projects that were working on in fact, when you are saying linkage to care, what are you saying? Linkage to care is to say to the people, you need to go to this place. Is this person arrived to this place for the first time? Was this person then came back a second time to get the treatment? And then if it took the treatment for how many months? So I think that there is a lot of lack of clarity on this linkage to care and evident need of working with hospitals, doctors, I mean, with the health system to assure that between what community is trying to do and the health system, there is not this gap in the middle that makes people then be lost to follow up, etc. And so, Danny, go. Please, the other.
So I think absolutely, it's interesting that lack of clarity about linkage to care. So in our mind, it's linkage to care is actually getting somebody initiated into treatment. And I think again, the way the systems here are working, it's very, very rare to have treatment initiated in anywhere but the community. Okay, so the hepatology teams, the Hep C kind of nurses will typically see people in a community setting, a homeless environment, drug treatment service, wherever it may be. I mean, a whole range of different services in mobile settings. Many of our projects have mobile clinic vans, so we can move into estates, environments, communities that have limited access to health and social care. So, as I said, the partnership means that nurses are appreciating, as they have done for so many years now, that actually you need to treat people in the community, not just test. Everything is done in the community. It's very, very rare that we'll take people to a hospital setting if they need a scan, for example. If we're monitoring if they are cirrhotic, that's slightly different. But for what I call, I'm being clumsy here, bog standard, a straightforward treatment, it could be done in the community. There's no challenge to it at all. We know this, the success. I looked at our data for last year in Birmingham, which is one of our 24 projects. And we found, I think, 260 people, maybe a little less, who are RNA positive. 97% of those completed treatment.
Yeah.
Okay. So we know that that model works. It's a very, very effective way. And for me, it's something that we learned, I'm showing my age here, back in the late 80s, early 90s with HIV, when healthcare around HIV was transformed because the individual with HIV was at the center of everything. We were learning. I was learning as an outreach social worker. The clinicians were learning. We were all learning because the individual was at the center, and all the treatment was challenged and changed around the needs of that individual. And for me, what we've in the UK, we've been able to largely replicate, if you like, mirror that experience we had many years ago in terms of how we treat people with hepatitis C. So I think the model in itself is easy to describe. Structurally, I get the challenges, absolutely, but it can happen. We've seen that change, significant change in terms of how healthcare colleagues work within communities now rather within hospital settings, for example.
Okay. Garba and then Gavin.
Okay. Yeah. Thank you so much. Let me on the video also now so that it can be seen.
Yes.
Well, I think linkage to care, I want to contribute in that area. It's very critical to the success of any care of hepatitis B or C treatment. The challenge with community-based testing, sometimes you test them in the community and give them referral. And linkage to care, as we all know, can be passive and can be active. Passive is, okay, you are positive, I'll give you a referral form to go to your facility for treatment, for viral load, among others. Active entails you ensuring that that person actually go there, through actually maybe escort services to facilitate transport service, among others. For instance, in Nigeria, we have communities whereby assessing healthcare will take them maybe 2-3 hours with a very, very bad road. So in those instances, you can refer them, they may not go, but sometimes we give them a gap. After 2 or 3 days, we call them what is happening, and some of them will tell you who don't have money to go. So for other HIV programs, what we do is we support them with some money for transports to go to their facility for care. That's why I say the linkage to care can be passive, but somebody can go spontaneously on his own, or active, where we have to provide escort services. So that's why, because of these challenges, for those that are on treatment, going back for follow-up is always a challenge because of distance and other cost issues. So we promote DSD model, differentiated service delivery, where they can get the services at their doorstep. It's always difficult, but we try to work on the program for HIV to ensure that we integrate the hepatitis program into the existing structures for HIV. So the same problem with return of result. You have referred a client to the health facility, viral load has been done for hepatitis, but when the result is back to the health facility, that client is in the community many hours ago. So also getting back the result is another challenge. So return of result, linkage to care. So these are things that we need to be innovative as community-based organizations to ensure that we integrate this program into other existing programs. So I think this is something I want to add, but whatever I want to do, we need to see how we can facilitate the linkage to care. It's very critical. Otherwise, we test them, we leave them there. For instance, last few weeks we were in a community. We saw a prevalence of almost 20% for hepatitis B and almost close to 7 for hepatitis C. We couldn't go back up to now. So we don't know how far they have, whether they have gone to the facility or not. That's why for this hepatitis testing week, we're thinking of going back to those communities again to see what we can do through the World Hepatitis program we're designing. So I think it's a big challenge. Linkage to care is very critical to the success of hepatitis program. Thank you. Over. Thank
you, Garba. Yeah, I will just like to react and came again to the monitoring thing, because sorry, Gabby, I give you the word right now. When we are saying that we need to be more innovative and there are challenges that persist, I really think that is in our, we can find solutions to this thanks to data. But this data for me needs to come from community. Let me tell you an example so you can understand better. There has been a lot of indicators used for knowing if young mothers, are adherent to treatment this is for HIV. And what the indicator is how many months after the birth of the baby, the mother keeps taking antiretrovirals. So what the people observe is that after 12, 18 months, the mother stop using antiretrovirals. And then they decide, well, women are not anymore adherent because the birth is done, etc. But when we spoke with the community-based actors, they told us it's not that they are not more adherent, is that they have to come with the baby. So it is not an issue of months, it is an issue of kilos, is that the baby is heavy. And if the baby is heavy, the mother cannot come to the clinic. You see? And then the intervention that you can propose is completely wrong if you are not identifying what are the real barriers for this testing or for this treatment. I hope that I was clear on that. Gavin.
Yeah, something I was just going to add in, very relevant to what Danny was raising before. When I was a national program manager, one of the big barriers we had was getting our patients to clinics so they could see the suitably qualified person to get the prescription. We do have prescribing rights with nurses in New Zealand, but very limited. It's a very expensive way for the nurses to go, and unless they're in an embedded speciality, it's highly unlikely they would. So I think we had 3 nurses nationally who had opted to prescribe Mavorite. So what we did was we changed the legislation, and we had a legislative change and enacted where nurses can do a very short duration course. It's about 3 hours online, and basically it's a little bit difficult to describe because we're not prescribing anymore. So if these nurses can establish that their patients meet inclusion criteria and don't have any of the exclusion criteria for receiving Mavorite, they can be given it by the nurses. And their supply of Mavorite for treatment is then backed by a retrospective prescription from a doctor at a later stage. The whole reason behind this was that getting patients to clinics, we just keep hearing it and hearing it. Community-based programs with linkaging to care shouldn't have, we need to get the patient to a clinic in the same sentence all the time. Our community-based screen to treat programs, we need to keep the patients where they are. If that person's been injecting for the last 20 years, their fear of medical, of authority, of anything to do with establishment is absolutely huge. And they're going to run a mile as soon as we start talking about getting them near any form of authority. By being able to keep them in their comfortable environment, lean in on the relationships that our peers have been building with them, and having complete from beginning to end screen treatment, continuity of cares, etc., is going to be a lot more beneficial and get us a lot more people across the line. I have heard of an argument that with comorbidities amongst a lot of the PWID population, getting them into a clinic to check them for other conditions is critically important. There's none of that the peer cannot manage. If they need further testing, that testing can be managed by a peer. If in vitro tests are legitimate to use in your country, that barrier is gone. Even with injecting injuries, I mean, the patients deal with them on their own, and peers often step in to help them. So, the whole argument that we need a qualified doctor to be on every single case, it doesn't wear well with me at all. And I've seen the results from limited trials that I've conducted myself with community programs to have no doubt whatsoever in the capability of peer-based community programs. All that aside, I don't know of any country that has a accident and emergency or a primary care system that's not overloaded, overburdened, doctors working stupid hours that they should not be working because it's making them dangerous in itself, and the list goes on. So yeah, I'm a big supporter of getting community, non-regulated workforce-based programming working wherever we possibly can.
Thank you, Gavin. Milani?
Yes, really, I also agree that it is difficult to link them with care services sometimes, especially when we had the screening program for injection drug users. We identified few people with positive screening test, and then we wanted to get further tests done. So for this, we were doing that from the STD and HIV services, and so we had to link them with the hepatologists for further management. And we gave them referral notes, but after that, the follow-up was not satisfactory. So really, in the recent past, in the country, in this area in this locality where injection drug users are common, community-based program has been established, and services are given. They are screening services as well as treatment, as direct observed treatment for positive people. As it is a small sample, small community, and as we do not have a huge problem with injection drug use at the moment, that is manageable. But otherwise, I mean, doing this sort of services throughout the country will cost a lot. So that aspect also we have to consider. And the other thing I forgot to mention is our country, as a low prevalent country, we were given HIV control status recently from WHO CRO office, and with that we try to move to the next step, that is elimination of mother-to-child transmission of hepatitis B. We have already, Sri Lanka has got the certificate for elimination of mother-to-child transmission of HIV and syphilis already in 2019. Now our issue is, I mentioned this in the questions also, important issues you wanted us to mention regarding the cost effectiveness, because we do have a problem with our authorities. There's a debate going on whether, as a low prevalent country, whether we should implement, whether we have capacity to implement mother-to-child transmission screening all mothers for hepatitis B. Because the numbers will be very small. So this is another aspect we have to consider, because that has to be, we have to eliminate mother-child transmission to move to the next level, that is elimination of hepatitis B. So these are issues we are facing at the moment. Thank you.
Thank you, Lilani. Are there any other countries, persons that want to share their experience? You were finally shy. So what I am going to propose you is that we are going to do some groups. You have spoken a lot on how to implement it. It's like how launching. Then there is this thing on the peers that are working on community-based testing. We have also speak about linkage to care. And we have also spoken about funding and not being able to do community-based testing or needing a professional health provider to do the testing. So what we are going to propose you is 6 different, I want to share with you, is, wait one moment. And what we are going to do is this. We are going to separate you in 6 different groups, one more based in implementing, one more on the roles of the different stakeholders, another one on delivering results, and how would you do it, another one in advocacy, how would you create a message or a strategy to work with your national program so community-based testing can be implemented. Another regarding emotional responses, And I would like to say that here, for me, there are two very important things. Of course, stigma and discrimination towards people living with hepatitis B or C, but also what means to provide a result. And I am saying this because in some big structures where I have worked doing community-based testing, there are people who don't want to do community-based testing because it's very hard for them to provide a positive results. And this is something that not always is spoken, because since everybody is convinced about the fact that we need to do community-based testing, is like, I don't dare to say that maybe I am not able to do this because it's too hard for me. And then another one on whatever you want, innovation, something that we forgot, any ideas. It's okay for you? Yes? Say yes. And the thing is that here are some ideas. This is an awful slide, but what we're going to do is that we are going to give you 20 minutes to work on this. And then you have to bring something to the group regarding what you have done. So if, for example, the group on implementation, maybe how we could implement this in a country that you have decided. So you need to choose a porte-parole. I don't know how is the word in English. Someone that is going to speak for the group.
Spokesperson.
Thank you. Regarding roles, how do you see these different roles? Regarding delivering results, what would be best practices? Advocacy, you can bring a draft of a campaign or of a strategy. When regarding emotional responses, what would you can provide as community-based settings for reducing stigma and handling emotions, and the others to bring new ideas or innovations that maybe could be implemented for improving community-based testing. Does it work for you? Yes? So we are going to separate you in 6 groups, and I will go to visit you. You will be selected randomly. And I will visit you to see how things are going. You have 20 minutes, and then you will have to do the feedback. Well, maybe we can do a brief, Justin, everybody's back, or we lost people there?
Yeah, this should be everyone now.
Do we start?
Yeah, sorry, that's everyone back now. Thanks.
Okay, so for the different groups that could do the exercise, can you please provide no more than 2 minutes feedback on what were the topics and what can you bring as advice to the other colleagues? So group 1, that it was implementation. I think that Bilani was going to be the spokesperson.
Yeah, thank you. Yes, we discussed some areas which are important for implementation. Really, we have to look at the policy of the country and the country strategy. Not only that, the attitudes of key population, that is also important. Then when we talk about strategy, we have to look at the prevalence level, and based on that, our strategy has to be formulated. And we can have several approaches. Sorry, I couldn't mention Dr. Pauline Chan and Dr. Alexandros. They were the other members of this team. Then under strategy, key population, we can have different approaches to different populations. Key population approach may be different, and the general population approach may be different. So in general population approach, in pre-employment and in antenatal care services or premarital screening, depending on the country prevalence levels, we can introduce testing. And also the importance of convergence of programs like hepatitis B and C services, coming together, or STI and HIV programs, having hepatitis services. also included there. That is another aspect we can consider. Then it is very important to look at the prevalence situation, because always our strategy has to be based on the prevalence levels. Then in blood safety, then hemodialysis, injection drug users, we felt routine testing should be there. It is already practiced in many countries. For others, opt-out testing can be encouraged, like other key populations. So we were just thinking whether we should consider homeless people, then migrants. In some countries, slum areas, some geographical areas may be there, which are having high prevalence levels. With that, we came to another concept, that is micro-elimination. Because in countries, to get support from authorities, we need to justify our services, why we should spend for community-based interventions. So if we can identify areas with high prevalence, districts or whatever localities with high prevalence, then we can say we are conducting pilot studies, and with that, we can justify our services. So we thought we can, in countries which do not have much high prevalence, we can start with micro-elimination and scale up services further. Then we had to think about service providers. Really, peers are preferred, but again, we have to look at the attitudes of the service recipients. We can use trained community peers or experts from the community, but we cannot forget primary healthcare workers and health volunteers who are easily accessible in communities. So involvement of them also will be really useful here. Then it comes to availability of tests. Point of care tests are needed when we reach the community, and the cost comes there. So that is another aspect we have to consider. And really, to take this program to the masses, we need social marketing for testing. So that is very important, another aspect we have to consider. So during the time given, really, we could cover only these areas. Yeah, whatever left, I think the others also can contribute. Thank you.
Thank you, Lilani. Thank you for this great input. We have the advocacy team that I know that was working correctly, so maybe we can, who was the spokesperson? Lani? Who was the...
we didn't get quite as far. I need to jump in there. There are only a couple of us really. I think from a Hong Kong point of view, I think there was public health there. I hope I've got this right. In terms of awareness weeks, is the one that's coming up. Lots of promotional work around Hep B with different themes each year, each opportunity. I think there's a kind of recognition that communities of people living with Hep B and their families are often kind of ill-informed. So there's something there about raising awareness, that element. And for me, kind of advocacy is a really key element of certainly everything that we kind of do in the UK. Advocacy for me and for us as an organisation is around building bridges. It's actually around having communication between people who are affected by hepatitis C, in this case, in our case, all the way through to support services and clinicians. And I think one of the reasons why we are successful in the UK is because I work with my colleagues, my peers, peer volunteers who have direct links to hepatologists, direct links to nurse specialists, to talk about people, talk about kind of clients, patients, talk about people's care. And I think there's an overarching kind of recognition that we've all learned from that. So the peers, my teams have kind of learned from the clinicians. Clinicians have learned and understood much more about the challenges that people face when they're, obviously we talk about stigmatized communities in the UK largely, and how those stigmatized communities, one, can have a voice, and also how those stigmatized communities, we see them transform. We hold people's hands, put them in front of a nurse, before kind of treatment, and you see the change, because often they've not had the experience of having a conversation with a nurse who isn't going to judge them, who doesn't judge them around their behaviors, their at-risk behaviors, or the fact that they're reinfected. So for me, advocacy is making representation, and I think it's a really key aspect of what we do, and I think a key aspect of our success. And it is a two-way process. For us, it's representing people with Hep C, but it's also helping those communities understand the practicalities, why certain obstacles in their minds are there and how we can help overcome them. So I think it's a really important process, absolutely. And sorry we weren't able to give you a more detailed breakdown. But I hope that's okay. I need to go in a couple of minutes.
Okay, we are just going to give yes, Justin, you want to say something? No? To the group of roles, I don't know if you had the time to discuss, and for the others, if you had issues, you can just provide a final feedback or reflection on what we have been discussing.
Yeah, I'll jump in here. In fairness, I don't think that we gave ourselves enough time to discuss it to give an adequate response. But what we did discuss, I think Danny just covered a lot of the points that we were entering into and we would raise. It's relationships, it really is. And you know, too many of us are living in fear of not being that doctor or that nurse with the specialist title. Danny just put it into a beautiful little piece there, that peer work in relation to working towards elimination isn't the challenge. The challenge is the stigmatism in the environment that the peers being thrown into, the lack of support and the lack of frameworks to assist them in safely undertaking the navigation of cares that they need to be undertaking. So again, I won't get too passionate and too personal about it, but I think it's been well covered. Peers need to have their roles respected and supported, I think would be the briefest way to sum it up.
Okay, thank you. I think that we need to finish. Thank you for all. I think that it was a very community-based workshop because it was more based on the exchange of experience, and I think that that's the best way of learning things. Thank you, you all, and keep in touch.
Thanks a lot, everyone.
Thank you. Bye.
Ciao, ciao.
Bye.